Okay, I think we might begin. We've had a lot more acceptances to this call, so other people may dial in as we keep going, but let's kick off. So welcome everyone. This is the first quarterly call of the Union Child Pneumonia Working Group. My name's Leith Greenslade, and I'm delighted to be joining Dr. Eric McCollum and Dr. Rebecca Nantanda as the co-chair. We have 3 co-chairs now for this group. This group's been operational for some time, but this year we're really making an all-out effort to increase the impact of the group. And Rebecca, Dr. Nantanda, will be taking you through our new work plan and all the activities that we're planning, which we hope we can engage many of you to work with us on that. Then we're going to hear from, we always want to showcase the work of a member of the group on these quarterly calls. And we're delighted today to have Justy Anthony from Qure. You may know they just received a large grant from the Gates Foundation to do some really exciting diagnostic work. So Justy will present that. And then we'll always leave plenty of time for you to share some of your updates. We don't want to miss any opportunity to learn from you or to elevate your work. So there'll be plenty of time. These calls are very informal. There'll be plenty of opportunity for you to contribute. So please use the chat as we go. Feel free to comment, ask questions. There'll be plenty of opportunity to pick those up. We'll record these calls and we'll actually post these on YouTube. So just be aware that whatever you say on these calls will be public. We're recording now, so just keep that in mind. So I just want to say 1 or 2 brief words about why we've decided to really try and hit the accelerator pedal on this group before I hand over to Rebecca. So as most of you will know, pneumonia is still the leading infectious cause of death among children under 5. We've just had a new round of data from UNICEF, I think last week, 2024 estimates. They're the most recent. And pneumonia was killing 660,000 children under 5. So no other infection causes anywhere near that number of deaths for children. So we have a high burden still, but we're also entering what we're starting to call a new era of pneumonia control. We have new vaccines that are incredibly effective. The PCV we've had for a while, but the RSV vaccine is here and the monoclonal antibodies are here. We have GBS vaccines in development, and we're not that far off a Klebsiella pneumonia vaccine. Altogether, we've never had a better way of preventing pneumonia in children than this basket of vaccines. As Justy will take you through, AI is really transforming the way we diagnose many things, and children with pneumonia should be able to benefit from that technological revolution. We have oxygen, a greater focus on oxygen than ever before as a treatment. That's due to COVID, and a lot of innovation in the oxygen space. And AI is also transforming antibiotic development. So you put all of that together, and we are at the dawn of a new era in pneumonia control. Pneumonia does not need to be the leading killer of children under 5 with all of these tools. So this group, we hope, will make a contribution by linking the science and the scientists with public policy decision makers, governments, to make sure governments are doing the best they can be doing with these new tools to reduce child pneumonia deaths. So I'm going to hand over now to Dr. Rebecca Nantanda to take you through what we're planning for the group. And we'd love your reactions to that when we get later on in the call. So I'm going to stop my video and share my screen. Rebecca, over to you. Rebecca, are you still with us? Let's see. Is Rebecca dropped?
Yes, sorry, Leith, I've just reconnected.
Okay.
My internet had dropped off. I lost you for a bit. Sorry.
That's okay. I just handed over to you. So if you want to take us through the deck, everyone can see that's our agenda for today. And I'll just move to the first slide.
Oh. Okay. Thank you, Leith, and good morning, good afternoon, good evening. Thank you for joining this meeting. So I'm going to take us through the work plan for this year. The goal is really to position our group as an expert scientific voice and convener for how countries really all over the world can reduce child pneumonia deaths by increasing access to what we know as the most effective prevention, diagnosis, and treatment tools, as well as practices. And then under this goal, we have 3 objectives. Leith, if you could move to yes. Our first objective, we want to amplify evidence and policy solutions with a capacity to again accelerate reductions in child pneumonia deaths. And our second objective is to strengthen the community of practice across child pneumonia researchers, as well as advocates that are linked to the union and beyond. And then the third objective is to influence the global agenda on child pneumonia. We really need to influence the global agenda, and this is through high visibility convenings and presentations at major global health events, so that we really raise the bar in the agenda on childhood pneumonia. So I'm going to go into the details of some of the activities we've proposed under each objective, and I'll start with the first one on amplifying evidence and policy solutions. So under this objective, we would like to have a dedicated child pneumonia working group web page, which we want to leverage the Stop Pneumonia organization. And if you click there, you'll find us there already, thanks to Liv. We are planning a quarterly email newsletter, and within this newsletter, we shall share some developments, upcoming events, any funding opportunities, any publications that are coming up on child pneumonia. We shall spotlight any of our members, and then we may have some messages from the co-chairs as the need may be. And then we also want to have a social media presence, really a strong one, using the Every Breath Counts Coalition, the Union, and other child working group member union channels, so that we really highlight our group moving forward. Under the next objective on, Leith, if you can move, please. On strengthening the community of practice, we have proposed that we shall have quarterly meetings. This is the first one, and these are open really to all members and non-members to listen to what we do. 3 of them are planned to be virtual, but we plan to have one in-person meeting aligned with major global events such as conferences. So we are thinking about the Union World Conference, which will take place in November in Brazil, or the Inspired Conference. This is purely on childhood respiratory diseases. It's going to take place in Italy in June. So we'd like to have one of them as in-person. We want to highlight the members and other relevant research. So any research that is coming up on pneumonia, whether it's from members or anywhere, we want to really highlight it. And then maintain a database on child pneumonia researchers, so that we keep really in the know of what's happening everywhere on the globe. And then under the third objective, the activities, this is on influencing the global agenda. And the activities we propose, we want to submit to at least 3 major global health events, including conferences, for example, the Union Conference, the Inspired Conference, the ICPPD Conference. These are annual conferences, so we want to submit to one of them or all of them this year. And then we want to support members to speak at major global health events. For example, the World Health Assembly, the WHO regional platforms. And then lastly, we want to host the annual webinar Pneumonia Day. World Pneumonia Day happens every year in November, and want to have a webinar as Child Pneumonia Working Group of the Union. So those are the activities that we are proposing. Next slide, please. So to summarize the timelines for these activities, so in the first quarter, which is ending this month, like I mentioned, to launch the page, we have the first newsletter, and we are having our first group working meeting, which is virtual. And then in the second quarter, we shall again have another newsletter, and then a working group meeting, which we think might be inspired in Italy. But we should be able to submit either session or symposium to the World Union Conference, which is, the deadline is on 9th April. So we really need to work quite quickly. And then in quarter 3, which runs from July to September, again, we plan to have another newsletter, which will be the third one, the third work group meeting, which will be virtual. And then the last quarter, which will be a little bit busier, we'll have the fourth newsletter, the fourth work group meeting, which might happen in Brazil during the conference, but also be able to have an impact summary on the work that we've been able to do through the year and then share with our group members. So those are the timelines. Next slide, please. So these are the co-chairs, like Cliff mentioned. I think to summarize this, we have Rebecca and Eric really looking at scientific leadership and representation at high-level meetings. I'm specifically looking at engaging a community of child pneumonia researchers and programmers and practitioners in the African region, looking at the researchers especially, and also making sure that we organize people to make submissions of writing to the conference. It's really mobilizing on the African continent. Eric is also looking at scientific leadership, representation at high-level events, global health, looking at for example, the United Nations engagements, as well as similar to me, submissions and writing. Liv is welcome on board. She's really leading all this about the newsletter, so she will be handling issues around the newsletter, the preparation, creation, and distribution to really maintain the web page, organize our quarterly meetings, including the logistics and promoting it, engaging the members and other influencers, as well as helping us really to perform to monitor how we are performing, as well as the reporting. So those are the summaries of the roles of the different chairs. And in the next slide, we want to say that in order to invite members, you're welcome to join our group. In order to join this group, you need to first be a member of the union. And then within the union, when you have your number, there are different groups, then you can select the child pneumonia working group. For people who are in low and middle income countries, we have an annual subscription fee of 25 euros, as well as for students. So students are still welcome. And then for all others, it's 150 euros per year. And just to say that everyone is welcome to join our quarterly meetings. So please, whether they are members or non-members, invite them. And we encourage people to recruit people into our group. Yes, so please join us. Thank you, Liv. I think this is the short presentation. Probably we'll have some comments or questions from the members. Thank you.
Thank you, Rebecca. I'm going to stop sharing. And yes, you'll all have this deck. We can send it to you, but I'd love reactions, comments from anyone. I know that's a lot of information, but we welcome questions or comments. If you're all absorbing all of that, we can move to Justy's presentation. And perhaps when we come to the end of the call, where we'll invite you each to sort of speak, you can ask any questions or make any comments then, if you still need to absorb that. So let me hand over to Justy. Justy Anthony, for those who joined a little later, Justy Anthony is with Qure.ai. You may know this company. They have been doing some extraordinary work in many areas and recently are moving closer to the child pneumonia area. So we're very grateful for that. But Justy, I'll let you explain exactly what you're up to.
Sounds good. Thank you so much, Neet, and the team for inviting us and giving us this opportunity. I'm Justy Anthony Churumal. I'm the Clinical Director for Global Health at Qure.ai. I come from internal medicine, tropical medicine, and epidemiology background. And for all who may not know about Cure, we started as a AI company that develops softwares for automated interpretation of imaging. But we currently have multiple digital health tools as well. But this is an extension of that program that we've been doing. So our AI softwares automate interpretation of chest X-rays, CTs, and we are currently deployed, especially in the context of TB lung cancer. We are deployed in 107 countries across 5,200 sites. So I'll briefly talk about specifically this particular project, which is revolving around point of care ultrasound. This is called BREATHE, which is an acronym for Building Respiratory Evidence for AI Tools and Health Equity. I forgot to check. I hope you can see my screen.
Yes, we can.
Okay, great. So this is called the Breathe project. So moving on, I'll just showcase a little bit of why we started and what we are planning to do. So, of course, we all know a point of care ultrasound has a role, given that it is portable, non-invasive, and radiation-free. And our idea being that we know that it can help in decentralization of the screening and triaging processes, especially in the context of pneumonia and TB, especially in children. So, a little bit about the overview. So, we had a planning phase, and then I'll come to the larger BEAT project details. In the planning phase was for about 3 to 4 months last year, where there were multiple objectives outside of the development of the larger project protocol. One of the main things we did was evaluating the different point of care ultrasound devices that are available in the market. So what we did was we started with 60 devices that we started evaluating. We spoke to multiple researchers, KOLs in this space. Some of the KOLs are actually on this call, and we narrowed down to about 12 devices that we thought were pretty good for the purpose of this large scale data collection that we are planning as part of the Breathe project. And in that 12, there was a team of one radiologist and an engineer from our side who went and did hands-on evaluation of these focus devices for about 10 of them, and we narrowed down and we had uh, a way to score objectively, as well as there is a lot of evaluation that is subjective, as you may realize. But we gave, based on the input from KOLs as well as discussion with the Gates Foundation, we narrowed down to four most suitable focus devices. There were essentially two types. So we are looking at one, every patient, every participant for this project will undergo ultrasound, thoracic ultrasound using two devices. One would be a standard high quality device, which would either be GEV scanner or Philips Lumify. And then there is a small scale, only the blind sweep, which will be done by one of the low cost devices, which will be between Leltec, which is from Taiwan, and Iran from China. We also evaluated multiple other data collection tools, right? Digital stethoscopes, for example. We evaluated about 5 or 6 different digital stethoscopes, and we narrowed down to AI diagnostics and eco-health. So every participant will have digital auscultation done by one of these devices. Outside of this, there are, of course, tablets, mobile phones for cough sound recording, etc. So coming to Breathe project, we the main two objectives is one is to create an open source, multimodal, geographically diverse database comprising of thoracic ultrasound images, cineclips, as well as chest X-ray, HRCT in a small subset of adults, along with their clinical lab results, as well as follow-up details we'll be collecting. I'll show you briefly what the list of variables that we'll be collecting. And the second main objective is to develop prototype AI models that can detect patterns of TB and pneumonia in adults and children. So we're looking at 4 different AI algorithms to be developed. It will be in this particular phase for Breathe, we will be testing the feasibility. There will be no product development planned. It will only be planned once we see there is a reasonable good performance. The idea impact being that we'll be empowering community health workers so that the POCUS device with AI, they will be able to screen and triage TB and pneumonia. There are multiple phases. Of course, the prospective data collection is the main 18 months, the main part of this Breathe project. But what we've also done is we've approached multiple retrospective projects that have completed and that are ongoing, and we've requested for their data also to be contributed towards this open source database. So we've actually started receiving some of the data from the previous projects also. For prospective data collection, these are our sites. In India, it's mainly CMC Vellore. In South Africa, it'll be University of Cape Town and Dora and Ginza Hospital in Port Elizabeth. And in Nigeria, which will be with University of Ibadan, with University College Hospital. We plan to recruit about 15 to 18,000 participants, both adults and children, to reach about 500 children with pediatric TB and 1,000 children each with pneumonia and 1,000 adults with TB and pneumonia. So this is the ultimate aim of the data collection. These are the data variables that we are planning to collect. So in history examination, nutritional assessment, the mandatory specific tests that we'll be doing is cough sound recordings using mobile phone, digital auscultation, as I mentioned, with the stethoscopes, radiology, chest X-ray for all participants, thoracic ultrasound for all participants, HRCT for all the uh, participants who have a diagnosis of TB and TB or pneumonia, and a similar number of controls. So about 4,000 patients will have HRCT. There'll be confirmatory tests, including culture in children, mycobacterial culture. In pneumonia, we'll also be doing pneumonia panel multiplex PCR uh, for the pneumonia, the patients who are diagnosed with pneumonia. And we'll also collect blood biomarkers. There will be final diagnosis based on composite reference standard by the site treating clinician itself. Follow-up is done for, we have planned for follow-up for TB in a period of 1 to 3 months after recruitment, and for pneumonia after 1 week. This is predominantly to help us figure out if any child who was diagnosed as pneumonia turned out to be TB, so that because our AI model will have to be trained based on what the diagnosis is. So we don't want it to so we want to ensure the diagnosis is correct. So if the clinically diagnosed child with TB, we want to ensure that the child actually has TB and not, let's say, lymphoma or something at the end of that period. So it's mainly for that sake the follow-up is included. I just want to briefly talk about the salient features of the project. What we are trying to attempt, which apparently has not been attempted so far, is to do a real-time quality check for the thoracic ultrasound. So what we are trying to do is, as soon as the thoracic ultrasound is done, both the images and cine loops, we will be asking the research staff to upload it on cloud. There will be radiologists at Qure who will be, we are expecting them to report back in about 20 minutes or so. If there is any images or if there are any cine loops that need to be repeated, if they are of low quality or if there is less gel, so they will give that feedback, which will come back to the research assistant, and they are expected to repeat just those points. This is just to ensure that we have good quality imaging database. And there are, of course, other parts, as we mentioned, it's multimodal data collection and the various devices that we will be integrating onto Qtrack. So Qtrack is a data collection platform from Qure that will be used for this this Breathe project that we've modified, customized. So we've integrated the various devices that we mentioned. Research assistant will upload the data on Qtrack. The site lead will do not all the records, but they will do QC on some of the records to ensure the data collection is adequate, the good quality. And QC radiologist on the Qure side is the one I was talking about during real-time quality check of doing the real-time quality check of the thoracic ultrasound images and cine loops. So all of them will be done through Qtrack, and that's something that we've developed over the past few months. Additionally, in order to standardize across sites, we've also engaged with Global Ultrasound Institute, which is an NGO based out of the US, but they have trained us globally. They are doing the training for both the research staff as well as the annotators who Qure will be engaging in India. And the portal we'll be using for annotation is RedBrick. All of this data, coming to the two main objectives I was talking about, is the open source data hosting will be done by Everwell, which is again funded by Gates Foundation. The plan is that this whole database, for at least for 7 to 10 years, they want to ensure it's openly accessible through this group called Everwell Health Solutions, which is based out of India. And the second point is the model development that I said would be Cure's responsibility. Just giving you a glimpse of Qtrack that we've developed for the purpose of this project. You can see that we've built all the forms. There'll be dashboards that will be coming in. there is a scan assist feature to help the research staff to follow the protocol that we have aligned for this particular project. So this is the customized QTrack version. Just wanted to show you a glimpse on QTrack of how the accept, like the real-time quality check, how we are envisioning is where if the as you can see, the radiologist can accept or reject images and cine loops, and that notification will go back to the research staff who can then retake the images and cine loops based on what the reports suggest. So this is what we've enabled on QTrack. We've also standardizing the data annotation. So the annotators will be trained again by Global Ultrasound Institute so that they are trained on the exact protocol and the exact need from our AI development perspective also. This is the uh, sorry, I'll go to this slide. So essentially, we'll have 30 to 40 annotators on Cure's side who will be engaged for about 18 months using Redbrick tool, where the all the images and scene loops frame by frame will be annotated. And all this annotated output would be in the form of Nifty files, would be repackaged with the original imaging data and all the clinical lab information, and would be transferred to Everwell for data hosting. Our plan is to transfer it every 2 to 4 weeks for the open source data hosting. So this is the main thing. I also wanted to add that we have, and thanks to a lot of the QLs and the researchers and the papers that have been published, we've managed to put together a comprehensive operators manual that would be very helpful for a lot of the people who are trying to start focus projects. We've also done video repositories and in the process of developing some more. Uh, we'll we'll make all this open source. We'll be putting it on a microsite, and that is can be expected in a month or so, at least the version one, so that those resources are available for anyone else to use as well. Our end product vision is that this is what we are thinking, that a community health worker will have a small bag with all of this. There'll be mobile phone, the ultrasound probe, the gel, and wire of wireless, and they'll be able to do a screening and figure out if this child needs triaging or needs antibiotic for pneumonia or needs to be referred for TB diagnosis, etc. So this is what our end vision is. I'll stop with this. The call to action from our side is to, if you know of any POCUS or thoracic ultrasound data that could be contributed to the open source database, please let us know. Is a request from our side. That's it from our side. Please, this is my email address. So feel free to reach out anyone, and I'm happy to answer any questions you may have.
Brilliant. Thank you, Justy. That was a great presentation. So any questions or comments from those watching? We have a quiet group today.
I have my colleague Nimi also on the call. Nimi, did you want to add anything?
Nothing at all, Justy. You've been very
Okay.
thorough.
Okay, great.
So I have a question. I'm not sure if we have anyone on the line. I think we might have from the IMCI Plus trial that the Europeans funded.
Mhm.
And there's a lot of work going on. There's a lot of things happening around and about. And there've been some calls for a community of practice to knit together all these different groups that are working on basically the same thing. Do you think there's a need for that, or do you think everyone is already quite well connected and you're aware of each other's work?
So IMCI Plus, I can see Veronic is on the call. Yeah, so I think we are well connected with most of the groups, and they have also been gracious enough to like plan to contribute this to this database as well. So, but I think there is a need to bring together people in a forum like this because I think everybody is working. I think we've also discussed with Brian and many others on this call. So I think it's a good way to bring together because to be honest, we are actually some of the new folks in the field, and I think we've reached out to them for guidance to Veronique, IMCI Plus, CADLAS for TB, Brian, and many other groups who's done this work for years.
Thanks, Justy. Shubhata.
Thank you. And thank you for such an excellent presentation and for just kind of getting this together for such a multinational group. I'm Shubhata Hooley. I'm a pediatric emergency medicine physician based in Houston, Texas. But I've conducted work and studies and lived in multiple different countries in the past, providing emergency care. And I study pneumonia. And my question for you is one, in terms of just awareness of different things happening with different groups. I know the US government, through a DARPA funding mechanism, which is generally focused on devices that can assist the United States military health program, has funded some similar work in pediatric pneumonia population in the United States. And I'm happy to offline connect you with the person that I know that was leading that work. But my question is, I think it's what's really unique about what you're doing is the augmentation with the inflammatory marker component of CRP, PCT, and CBC. Will there be any samples that are remainders that might be stored for additional types of testing? For instance, there's just a number of different biomarkers that are being explored. There's an ongoing study in the United States looking at markers that assist with prediction of pneumonia severity, as well as markers that assist with prediction of bacterial versus viral etiology of disease.
Yeah, thanks, Dr. Shubhata. We'll definitely connect offline with the person for sure. But about the biomarkers, we are actually not doing we are not doing a biorepository of any of the samples. We are actually going to just test because we just don't have the expertise nor the bandwidth to get into that space. So there'll be no samples that will be stored from this particular project. Yeah, unfortunately. So yeah, and so we had to take a call because there were multiple data points that we had to focus on, and our main thing was biomarkers. Also, we are hoping it will help. It will help in the subsequent phase. It will, of course, help in the composite reference standard part of the diagnosis. But we are hoping at some point, maybe a couple of years down the line, that we can knit that also as one of the into the tool, into the AI algorithm, so that that can also be built in. So that is in the pipeline. Yeah, but there is no biorepository.
Thanks, Justy. Veronique.
Yeah, hi Lee. Thanks so much for organizing, and hi Justy. Thank you for a
Hi.
great presentation. It's really amazing to see how this project has pushed forward. And I had two comments. So first, for a community of practice, I also sincerely believe that this would be helpful. First of all, because we're of course still many groups with a common goal, and I think it would definitely facilitates the building of evidence and strengthen where the evidence comes from. I also think it would definitely help in facilitating the industry academic cooperation. And I also think it would be very helpful in just opening things up, not everyone being in their vertical small little corner. So I can speak for CADLAS for TB. So we're really in the TB diagnosis space. But of course, the most patients we test for TB, they basically have something else. So to really open up that horizontal diagnostic landscape as a community. So I'm very much a fan of the idea of a community of practice for these multiple reasons. And then on the biomarker question, it's very early day, but I just wanted to share that we are writing a proposal where we want to analyze 4 different cohorts that have lung ultrasound on patients with suspected lower respiratory tract infection, where we want to do microbiology work and biomarker analysis on the biobanks of the cohorts to move more towards the space of differential diagnosis between viral and bacterial pneumonias on lung ultrasound. And the 4 cohorts are 2 in Switzerland in emergency departments and in elderly homes. And then there's the IMCI plus cohort in children in sub-Saharan Africa. And there's the TB ultrasound cohort in Benin. So we're in a proposal writing stage for this idea. So of course, very happy if other people would like to join this idea. Thanks.
Thanks, Veronique. How do people reach you on that? Do you want to put your email in the chat, perhaps?
Yep.
Thank you very much. Rebecca.
Yes, thank you, Justy. Very interesting. My question is around the diagnosis of pneumonia. Practically in children less than 5 years, especially in our setting, many times it's difficult to just think whether this is pneumonia or something like asthma or bronchiolitis. There are many children who have asthma, but they're not actually wheezing. And so I'm wondering how you will or what plans you have in place to ensure that actually where you're testing the tools actually pneumonia, and you just want to know whether it's maybe viral or they need antibiotic or not. Yeah, really distinguish between the infectious and non-infectious causes of acute respiratory problems in children. Thank you.
Absolutely. And I think that is going to be a problem that we will also face. Because we were thinking of doing like a panel also at the end, but it was just not feasible within this project to have that. So what we are going to do is we are collecting all the clinical history, all the examination, including SpO2. We will have their chest and drawing, the danger signs collected. So we have an extensive list of data variables that we'll be collecting. And we're hoping, including the chest X-ray, procalcitone, and CBC, all of it, and the site clinician's diagnosis based on all this, and as well as the pneumonia panel, is what they would be giving us the diagnosis, whether it's going to be pneumonia, not pneumonia. And not pneumonia will serve as our controls at the moment. So we are going to go to your point question, we are going to go with the site clinicians diagnosis based on the multiple data variables that they have is at the moment is what is planned. And we will, of course, annotate the chest X-rays that are coming as part of this project. We are also collecting, so what we didn't show is we have provision to collect additional data. So if the child has undergone a CT scan or has undergone a bronchoscopy, we have made provisions on Qure.ai on the data collection platform to capture that information also. Again, it would be based on the research staff and the site clinician and investigators to complete all the supportive evidence for the particular diagnosis. Yeah, I think we'll have the same problem. We will face issues where there is overlap of bronchiolitis or exacerbation of asthma. Yes, but this is where we are at the moment. If you have any suggestions, it would be great, Dr. Rebecca, and I'll be happy we can also do an offline discussion on what we are planning. It would be great to hear your insights as well.
That's a good idea. That's a good idea. We can have one more question and then we need to move. So Gildas.
Thank you. So my question is about the level of the site. Was it the primary care site, or hospital level? And had the clinician been trained before to be sure to the quality of data? As we can know, at the primary care, some clinician is nurse, and the level of competence or skill is not the same as the medical doctor.
Great questions, thank you. So the first point is about the sites. So there will be hospitals There'll be community-based outreach recruitment in South Africa alone, but others would be from primary health centers, DOTS clinics, and hospital outpatient department, emergency room, and inpatient wards is where will be recruiting the study participants from. It's only a small proportion of the screening, sorry, there'll be a 5%, 5 to 10% population from South Africa from the community screening. They do this targeted community screening specifically in the context of TB, where they see 5% prevalence of TB. So we'll recruit a small proportion from the community only in South Africa for adults. So that is the only difference from the adult and pediatric recruitment. To your point of who will be doing the data collection, so as part of the training, our actually Nimi and team colleagues had actually done a 5-day training in Nigeria, where 3 days was done by Global Ultrasound Institute for POCUS acquisition training, and 2 days on the protocol and the data collection platform as well. And we're continuing to do hand-holding and refresher training. But the skills of the people who are doing data collection is different in different settings. So I just wanted to highlight that. We wanted to bring in variability in terms of the people who are doing the ultrasound capture acquisition. In India, given that there is this law called PCP&DT where there is restriction on doing ultrasound because there has been female feticide and gender sex determination in obstetric ultrasound. So there is restriction on who can do ultrasound in India in general. So in India, we can only get ultrasound acquisition done by medical doctors. So that is the path we're taking in India. In South Africa, the acquisition will be, at least the ultrasound acquisition will be done by nurses. And in Nigeria, it will be done by a mix of nurses and very young epidemiologists. We are actually training. A lot of them have not had any exposure in lung ultrasound. That's why they are getting trained. And the training is not for them to identify abnormalities. So that is something that what we are trying to do is training them on a protocol because we want the images and acquisition to be done following a specific protocol. So that is what we're focusing on in the training. I hope this answers your question.
Yes,
Yeah.
thank you. But the
All
fact will be that if the clinician makes some measurement which is not good, it can become an issue for the interpretation by the data collector and by the system, no?
The clinician, you're saying like if they're
The site clinician.
yeah, if they make a mistake, like if it's pneumonia or is that what you're trying to say? Sorry.
Yes, exactly.
Okay. Yeah, definitely. So that is unfortunately, I think we have to go with that because I think pneumonia, unlike TB, at least we have a chance of getting some kind of bacteriological confirmation at least. But in pneumonia, we'll have to go with that composite reference standard, and we are trying to collect as much supportive evidence for that as possible.
Okay,
Yeah,
thank you.
definitely we agree. Yeah.
We're going to have to move on, Darcy. There's lots of interest, clearly. And I'd ask you if you can answer in the chat, you or Nimi, the question from Shital. There's one in the chat for you. But thanks
Yeah.
very much.
Okay.
Thanks very
Yes,
much for
thank
that.
you. Thanks.
So each time we have a quarterly call, we'll do this again. We'll highlight a member and their important work. So if any of you have work you want showcased in this way, we can absolutely do it on these calls. But we have some time now to hear from you. We've got a good 10 minutes that we can dedicate to this. And what we want to know is any important child pneumonia research or related work that you and your teams are doing. So I'm going to open it up now, and please do share because part of the purpose of this group is that we know what each other is doing and we support each other. So. And if no one says anything, I don't want to conclude there is no other child pneumonia research work going on.
Leet, if I may, I just wanted to add one more tool. Sheetal, I'm responding to your question also in the chat, but I just wanted to add, Leet, one more thing that Qure has been working on is our AI co-pilot. It's called Ira, which was launched in May last year. It is a kind of a digitization, voice to text, image to text digitization tool, as well as a clinical decision support tool, which is like a glorified reincarnation of like the chat GPT that we have, but to empower community health workers. And we are doing a lot of work to decentralize ART programs and also outbreak response. So, for example, we are working with the Gates Foundation and Village Reach in Mozambique, where IRA, which is a co pilot, would listen to the public health emergency response helpline to detect any outbreak signals. And this is not restricted to respiratory, it can be anything, could be cholera outbreak or, yeah. So, this is another tool which we can showcase maybe in one of these sessions, Lead, if you allow, in the next few meetings, is something that we can get some pilot data also out by then. Because we are having deployments at the moment in Mozambique, Nigeria, especially for the HIV programs. Um, yeah, and Kenya and Bangladesh for pharmacists to detect if there is somebody who's coming to the pharmacy to be referred or not, and who needs triaging kind of a tool.
Feel free to put that link in the chat, Justy, as well to Ira.
All right, will do. Yeah.
Great, thanks. So Eric McCollum has joined us. Welcome, Eric, the third co-chair for the group. Eric, we're just opening up the call for work from relevant child pneumonia work from other members of this group and people on the call. So we have some pretty formidable researchers on this call. I see Chris Reese, I see Mark Newman, I see others. Anything you're working on at the moment that we need to know about?
I would hardly call myself formidable, Leith, but since you called me out by name, happy to chime in. A couple of things myself and others on this call are working on domestically in the U.S. that I keep wondering about their applicability in low and middle income countries are one, watch and wait antibiotic prescription studies. So as we've learned from Perch and the EPIC study as well, most children with community-acquired pneumonia have viruses detected instead of bacteria, yet recommendations are they all get empiric antibiotic therapy. So what we're doing with the watch and wait study, or it's called STAMP, is a multi-center randomized controlled trial where children with community-acquired pneumonia who are well enough to go home from the emergency department or from an outpatient healthcare center are randomized to either receiving the amoxicillin prescription and starting it as is current practice when they're diagnosed with community-acquired pneumonia, either clinically or radiographically, or they are told, hey, keep an eye on this, and if your child's not getting better in 72 hours, then go ahead and start the antibiotics. But I think a lot about like IMCI plus and all these other studies, like and the comments that were made earlier about like the diagnosis of pneumonia. I've gotten to the point where I think the real question is not which child has pneumonia, but which child needs antibiotics for that pneumonia because it's such a heterogeneous diagnosis in many ways. But anyway, so that's the STAMP trial, and happy to talk more about that or connect people with the overall PI. I'm just the site PI for that one. And then similarly, and Shubhita can feel free to chime in on this as well, but we have another multi-center prospective observational cohort study, again, domestically in the US, but direct applicability in resource-limited settings, where we're trying to derive and externally validate a risk assessment tool to identify the child who has pneumonia, is not severely sick at that time, but hours to days later goes on to develop severe pneumonia. So we're trying to risk differentiate those from the children who are could potentially be safely managed at home. So since you called me formidable, I had to say at least something, Leith, but
No, I knew it would work.
hardly formidable.
I knew it would work. This is exactly what we want to hear. So there's two things we're going to add to our list because we maintain a database which you'll all have access to of this work. So Chris, that's perfect. If others with initiatives like that could either drop them in the chat or come on the call, that would be great.
I'll just
Sure. And
oh, sorry.
Go ahead, Mark.
that's
Oh yeah, no, I just wanted to say this group is so impressive, Justy. Your project is amazing. I can't even imagine the amount of time you put into setting this up, and it's going to, I'm sure, glean some amazing results. So big congrats for setting up this group. I'm excited for the group. I'm excited for your study. In Boston, we've continued to do some work, obviously in a very different setting. In a tertiary care emergency department in the United States, we've done a lot of work, mostly looking at ultrasound in comparison to chest X-ray. Joshua and Cindy are on the call as well in our group, but we're just super impressed with this group, and any way that we can be helpful, I think just reach out. We'd love to sort of get involved, but this is really amazing work. So thank you for what you guys do.
Thanks, Mark.
Thanks, Mark.
And the rest of your team. Someone else, I just cut someone off too. Who wanted to speak?
Oh, no, that's fine. It was me, Shubhra. And I'm not sure if Eric has previously brought this up. This is my first time having the opportunity to attend this meeting. I'm leading some work in the United States focused on pulse oximeter accuracy in children with different skin tones. And so we're doing that primarily in the intensive care units. And then Eric and Andre Guy are leading similar work in Cape Town as well at Stellenbosch University. And we'll be presenting some of our preliminary findings at the Inspired conference. So I'm looking forward to meeting many of y'all in person there.
Great. Is that with Mike Lipnick and UCSF, Open Oximetry? Is it connected?
We're all connected, yes.
Great.
Mike's been just a wonderful support and source of fantastic information. Yeah.
That's great. Good to know that. Okay. We've probably got one more minute. If anyone else has any work that's relevant, please don't leave this call without telling us. Okay. Otherwise, we're going to pivot to next steps. Thank you, Justy. There's Ira. Oh, it's A-I-R-A. Ira. That's very clever. Okay. So I want to thank Justy and Rebecca and Eric's joined us. This will be the cadence of these calls quarterly. You'll have an update from the co-chairs. You'll have a member spotlight and then open mic really for you to share some of your work. So just let me wrap up what we're going to be doing this year. So you'll get every time you come on a quarterly call, there'll be a newsletter that will send out immediately afterwards. The newsletter is live on the website. I'll put the link in the chat in a minute, but you'll get it in your inboxes as well. And we hope it's helpful to you, but if it's not, please do tell us. We're rounding up the latest developments, the events that are coming up that are relevant for childhood pneumonia, and really critically the funding opportunities. So we're using AI to source funding opportunities. So we hope we're going to be very comprehensive here. There's not that many, as you all know, related to childhood pneumonia, but there are some. So we'll try and get a good list of those and put those out quarterly and encourage you to apply. We'll also make sure you know the conferences that are coming up, and if we can join forces on submitting proposals for symposia or sessions, we should use this group to do that. So the next one on my list is ISPPD, which is the pneumococcal disease conference in Copenhagen this year from I think it's the 17th to the 20th of May. We have a session there on pneumonia control on the Sunday, the 17th of May. So that's a 3-hour workshop they've given us. So if you're in Copenhagen, let me know, and you would be able to come to that workshop, or perhaps you'd even like to speak at that workshop. We have that event, which is great. Inspired has been mentioned several times. I think that's in June in Italy, in Bologna in Italy. We will have a meeting there face-to-face. That'll be our next quarterly meeting. But we'll also be doing, we hope, several conversations around childhood pneumonia, so we can ensure that group, that conference has a strong focus on childhood pneumonia. And then there's the big Union World Conference on Lung Health in Rio, which is in November. I think that's around 17th to 20th of November, but I'd have to double check. We're submitting for several symposia there. The deadline is the 9th of April for that big event. So the clock is ticking, but there's a group of us working on some submissions there, including on childhood pneumonia vaccination, and other aspects of the challenge. So if you'll be at the Union in Rio, please let us know, because we're putting speakers together for these different sessions, and if you're there, we don't want to miss you. You're also welcome to join the submission itself and help us work on it. And if there's any events you're attending, tell us so we can use this network to support. I think that's all. I'm going to just invite Rebecca Nantanda. I don't think Eric can speak. He's in an airport. Just invite Rebecca to give any final comments while I drop some links into the chat.
Thank you, Liz. I really just want to thank the members for making time to join this call and for the discussions, and for Justy for really presenting this work, and for the rest of the team for sharing what you're doing. It's very encouraging. Please look out for the next meeting and also visit the website to check on the updates as they come along. Thank you, everyone, and back to you, Liz.
Great, thanks, Rebecca. So I've just dropped in the chat. This is the first link is where everything will be hosted for this group. It will be hosted on the website I manage for Every Breath Counts. It's called stoppneumonia.org. And then you'll notice if you go to the Union itself, the Union has a dedicated web page on this group. So check that out. We're going to be very active on social media, amplifying the work of this group. And as I said, I want to close with what I said at the beginning. We really have entered a new era of pneumonia control with better vaccines. AI is transforming diagnosis, and the treatment area is, I think there's been some great investments in pulse oximetry and oxygen. We have a lot more work to do in antibiotics, but we're hopeful that this group can also weigh in there. So if you look across the prevention, diagnosis, and treatment landscape, that we now have the tools so that pneumonia doesn't need to be the leading infectious killer of children. We know we're a small group, but we really want to make an impact on the global conversation this year and in future years to get governments to adopt some of these new tools and strategies so they can really get their childhood pneumonia burden under control, prevalence and mortality. So we hope you'll stay connected to this group and invite others to join. You don't have to be a member of the Union to participate in these calls or read our newsletters. Of course, that's an option open to you if you want to officially join. So thanks, everyone. We'll send the link to the recording, and we hope you'll join us for our next quarterly call. Thanks, everyone.